spent 1 year as a staff surgeon at the Addis Ababa Hamlin Fistula Hospital, where she served women with childbirth injuries. She then returned to the US and completed her fellowship in female pelvic medicine and reconstructive surgery, as well as her master's degree in clinical research at Oregon Health and Science University. Following her training, she served as the division head of Urogyn at Kaiser Permanente Northwest and was the director of global health and OBGYN at OHSU. She was recognized for her clinical work and leadership as the 2018 recipient of the Kaiser Permanente Distinguished Physician Award. Global Fund for Women named Dr. Nardos a Mama Hero to recognize her contribution to global women's health. At OHSU, she founded Footsteps to Healing, a global women's health initiative which provided team-based surgical services to rural Ethiopian women with severe pelvic floor disorders. In 2015, Rahel joined the board of the Worldwide Fistula Fund, and I'm there on the board with Rahel, where she currently serves as the chair of the programming committee to support capacity building in the care of women with childbirth injuries in multiple countries in Africa. As part of her leadership role, Dr. Nardos has been involved in the creation and ongoing support of the first formal Urogyn fellowship program in Ethiopia. In 2020, Dr. Nardos co-founded and currently serves as the vice chair of Global Perm Northwest, an NGO based in Portland, Oregon, created to build healthcare capacity in low resource settings. Dr. Nardos is the immediate past chair of the American Urogynecologic Society Global Health Interest Group. Dr. Nardos joined the University of Minnesota in August of 2020 as an associate professor in the Division of Female Pelvic Medicine and Reconstructive Surgery, and she's the director of Global Women's Health within the Center of Global Health and Social Responsibility. Over the past years, I've really just felt honored to work and talk to Rahel about many things, not only in FPMRS, but particularly in global health. She has extreme vision and is really committed to helping women that are disadvantaged. And today we're going to hear her speak about reimagining global health engagement in FPMRS. Rahel, thank you for agreeing to be here, and I look forward to your talk.
Oh my gosh, thank you so much, Holly. Can you hear me?
Yes, hear you just fine.
Okay, great. Thank you for that wonderful introduction. And I'm really, really happy to be here. And I'm honored to be here to share with you a little bit about my perspective on global health in general, and also as it relates to female pelvic medicine and reconstructive surgery. Hopefully we'll have a little bit of time at the end for you to ask questions. It has been an honor to serve with Holly on the Worldwide Fistula Board and continue to serve with her. And I'm really, really happy to be here. So, I don't have any disclosures. I like to start by sharing with you this quote by Lila Watson, who is an Australian Aboriginal elder. And this quote actually really reminds me of the meaning of global health and or community engagement, for that matter. She said, "If you come here to help me, you're wasting your time. But if you've come because your liberation is bound up with mine, then let's work together." To me, this quote says that we live in an interconnected world, and what happens to one of us affects all of us. And we are only as strong as our weakest link. And I think, the pandemic has hopefully taught us that and is continuing to teach us that. So helping to advance the well-being of others should go beyond, charity or ethical obligation. It should be motivated by the understanding that we are collectively so much better when we work together to achieve our fullest potential. So there's a wise Ethiopian saying, I grew up in Ethiopia, so I've heard this all my life. that says, when spider webs unite, they can tie up a line. And this is kind of the way I like to think of global health. So let's look at global health through this lens, the lens that says your liberation is bound up with mine. I have something to teach you, and you have something to teach me. And when we bring our collective wisdom together, we can create a more lasting legacy. A healthier world, a better world for our children. And as Jonas Salk, who is the man who developed the polio vaccine, once said, "Are we being a good ancestor?" So it will be a disservice to talk about global health without also revisiting its historic legacy, which, by the way, still implicitly and explicitly impacts our ways of engaging with the world. So I'm going to take you into a very quick journey into the history of global health to give you some perspectives. So, the early version of global health started with colonial medicine. So during the colonial era in Africa, the British and the French controlled 95% of the African continent. At this time, the goal of global health was to prevent and control disease from spreading across the colonial sites, and also to protect the colonizers from bringing disease back to their continent. So, research field sites that were set up in sub-Saharan Africa, for example, by the British and by the US in the 1800s, they were intended to study and understand tropical diseases, not because they wanted to protect the communities at that time, but to prevent these diseases from spreading to Europe and the US. And this has really big implications on how large research centers in sub-Saharan Africa are viewed by the public, even to this day. During this time was also the famous International Sanitary Conference in 1851, which was really emblematic of this time. And the primary focus of this conference was to coordinate quarantine requirements in the European colonial power nations. So international health was seen as more as a critical security issue for Western powers. And really, this still persists to this day, where global health is often seen in the context of foreign policy and health security. So then, we come to post-Second World War in 1946 to 79, which is the international health movement. And during this time, the focus kind of changed, where we became more concerned about health problems and challenges in low-income countries. And we started thinking of this as a more humanitarian type of approach. So the main focus during this time was on measures to prevent and treat infectious diseases still, to improve hygiene and access to water, and improve maternal and child outcomes. So more concern for local communities. But there was still a political undertone, right? Countries were largely divided into the Western Bloc and the Eastern, the Western capitalist bloc and the Eastern communist bloc. And then there were all these other countries that were less affiliated, that were kind of the third world countries. And the Eastern and Western blocs competed to have influence over these other countries, including influence over their healthcare systems. So the creation of WHO also happened during this time. And there was a big push on single disease type of eradication efforts, or a more vertical approach to care. And this approach, is still somewhat pervasive in global health, although it has shifted. Although it's been successful in certain disease processes like the polio eradication or chickenpox or HIV, it has been criticized because it doesn't always address the broader health concern of communities and strengthening of health systems. So the question then was, and still is now, are targeted interventions sufficient to achieve sustainable health equity? And this is a good perspective to think about, because this is also partly what we're seeing even in our own field of pelvic floor reconstructive surgery, that targeted approach of surgical intervention over a short period of time. There were some promising highlights during this time, such as the signing of the Alma Ata Declaration, which is a really important history to know, actually, if you're involved in global health. It was a declaration that was signed by 134 countries in 1978 at the International Health Conference on primary healthcare. And what this declaration defines was, it was saying that primary healthcare is an essential healthcare and emphasizes that the governments have a responsibility for the provision of adequate healthcare for all, while also acknowledging that individuals and communities need to have some accountability and engagement. And so it was widely viewed at that time as a success for low and middle income countries to achieve health equity. But, this did not last very long, because with the fall of the Eastern Bloc and Eastern Bloc countries like Russia, neoliberalism proliferated, where health was thought to be best achieved by market forces. So basically, privatization of healthcare. This sounds pretty familiar for our setting. So in global health, following this legacy of colonialism, this kind of neoliberalism ensured, more power disparities between the haves and the have-nots, the stakeholders and the funders and the recipients of the funds. Who sets the agenda for the research? There was a lot of power differential in terms of control and ownership of the decision-making power, determining research questions, programming priorities, and allocation of funds. And this is still with us now. During this time also, there was the structural adjustment programs, which were set forth by the international financial institutes like the IMF and World Bank. And they were developed to ensure that low and middle income countries restructure their economies so that they can control inflation and they can pay back their loans, and they can stimulate their economic, growth. And what they did is this international monetary funds provided loans and debt relief to these countries, but under the requirement that they promote free markets, that they privatize state industries, including healthcare institutions, and deregulate economic activities. And of course, you can imagine how this was a 360 turn from the policies that were from the declaration of the Alma Ata, which was kind of more universal healthcare and a more involvement of governments to ensure those basic healthcare aspects. So here we are now in the modern phase of global health, which is, some call it planetary health, which is a movement more focused on people rather than disease processes, and deals with the reduction of healthcare disparities and inequities, so that more people in the world can enjoy better health. So this is coming closer and closer to that, lens that we talked about at the beginning, which is good. And under this version of global health, understanding the social, environmental, political, structural determinants of health becomes really critical. And the idea of shared decision-making with communities, and focusing on building healthcare resilience through strengthening of health systems. So this is kind of where our aspirations lie. Whether or not we're really up to the task and are doing it is another story. So here's a nice definition of global health for our times, an area for the study, research, practice that places a priority on improving health and achieving equity in health for all people worldwide. I also like to just emphasize here that when we think about health, it's important to note that direct health care contributes only to about 10% of overall health, right? The rest is determined by social, political, environmental, genetic, and individual factors. And so what this means to me is that if we don't get out of our four walls of our medical institutions and work with the social scientists and the community leaders and champions, we will not make a meaningful impact on health. And this is true in low-income countries as it is true in high-income countries. So let me go a little bit more specific when it comes to women's health, since this is kind of our topic of conversation. Women obviously bear the highest burden when it comes to health disparities, particularly in low and middle income countries, particularly in rural communities, because for various reasons. One is that, obviously, the burden of pregnancy and childbirth related complication is obviously solely borne by women, right? And most women go through multiple pregnancies, particularly in the absence of readily available obstetric care and reproductive health care services, thus putting their lives and their bodies at risk over and over. But what makes them even more vulnerable is that they also happen to be the most disempowered in most communities. They get pulled out of school as young children for domestic labor. They get denied education. They're given in marriage at a young age as children, actually. They get circumcised. They get beaten by their partners as an accepted form of discipline. They get raped as weapons of war. They don't make decisions over their own bodies, and on and on and on. So, the woman in this picture that you see, she died under my watch when I first started working in Ethiopia. I was a second-year urogynecology fellow, and it was in a rural district hospital. And she came in after 3 days of labor at home and was delivered by the OBGYN there by C-section. But she developed sepsis soon after her C-section. Her baby was alive at that time. And they had to take her back into the operating room to remove her uterus because her uterus was infected and she was septic. But she just declined. She continued to decline. And I remember, our team was there to do pelvic floor care surgeries, but they were involved in trying to resuscitate this patient, and they were bagging her all night because there was no critical care capacity there in that hospital. We donated blood. I mean, no one could save her life, and she died. And I heard that her baby died a week or two later as well, because there was no mom to take care of the baby. And I will tell you that was kind of a wake-up call for me, because I realized that we're just functioning in a vacuum when we go and do this surgical procedures, because the whole health system was not working well, and we're not looking upstream enough. And that was kind of one of the turning points, I would say, in my own kind of way of thinking about global health. And of course, beyond maternal death, it's thought that for every woman who dies, there's 20 or more who have other pregnancy and childbirth related complications, such as fistula, prolapse, bowel, and bladder incontinence, and a lot of other things as well. So we're going to focus a little bit on this today. So let's start with obstetric fistula, because that's what gets most attention by global health professionals. For those of you who might not know what a fistula is, it's essentially if a woman goes into labor and is not able to have the baby vaginally, either because the baby is too big, or the pelvis is too small, or the baby comes the wrong way, or the uterus is not contracting adequately. All the reasons why we usually, if they were having babies in our hospitals, we then progress to C-section or other operative delivery. But imagine if the woman is having baby at home because for many, many different reasons, she's not able to access care because there are no obstetricians nearby, or because she can't travel to this location, or she just doesn't have a voice in terms of advocating for herself. For these reasons, she doesn't get to where she can have a C-section. If she goes for 3 days in labor, the baby's head will get trapped in there, and it would cause ischemic injury through the compression of the tissues around the head to the vagina, bladder, and or rectum. And this ended up leaving the woman causing a hole in the bladder or the rectum, and she can become terminally incontinent of urine and feces. And it's a devastating condition for the physical aspect of it, but it's even more devastating from the social and psychological aspect of it. It should never happen. It's a disease of poverty, and mostly in low-income countries. You don't see this problem generally in high-income countries. The treatment for this is surgery, and there are very limited number of cases that you can cure with just catheterization if they're very, very small, but mostly this woman needs surgical care. And surgical care is very complex. So, Dr. Richter knows what this involves because she has been involved in this kind of care in Niger and other places. Sometimes the fistula, if it involves just the bladder in the middle of the bladder, for example, a nice little hole, it's easy to repair. But if it involves the urethra, which is your continence mechanism, or have a circumferential involvement where the urethra is detached from the rest of the bladder, this can be very complicated surgery. So you need very skilled surgeons to do this. And they can be very difficult to cure even with that. One of the really important things to note is that getting the first surgery in the hands of very skilled surgeons and care teams, that includes nurses, because both the pre and post-op care is just as critical as the surgery. Getting that first surgery in the hands of comprehensive caretakers and experienced caretakers is so important, because once you fail that first surgery, your chances of getting healed through recurrent surgeries is much, much lower, just like any other surgical outcome. So this is important. I want you to remember that, because I will talk a little bit later why the current model of care for these patients doesn't always meet this. There are also patients whose bladder might be so severely damaged that you may actually have to do diversion surgeries. Sometimes the ureters can be detached from the bladders, so you have to do ureteric reimplantation. And all of this require even more advanced surgical skills. This is a big challenge in low and middle income countries, because not only are the surgeries done by many different visiting and local surgeons at all levels of expertise, but also usually, not a good system for long-term follow-up, right? To enable tracking of your outcomes and maybe even improving quality over time if it's being done by multiple teams at different times and with no continuity of care. Up to 40% of fistula patients can continue to have persistent incontinence, and this is a big problem. We did a study in Ethiopia and Uganda and found that this persistent incontinence is very moderate, has a moderate to severe impact on their quality of life. And a lot of it is extremely severe incontinence in these patients. Even after the hole in the bladder is successfully cured, you can continue to have leakage through the urethra. You can have overactive bladder. You could have very severe stress incontinence. And it could also have really significant impact on mental health. For example, we found that between 24 to 32% of women who have had fistula repaired have suicidal ideations. And among those who reported suicidal ideation, women with persistent urinary incontinence were 2 times more likely to report having made plans for suicide, and 6 times more likely to have attempted suicide. And there's very little ongoing care that's available for these patients because most funds or funding organizations or even healthcare providers who care for these patients, they stop once the hole in the bladder is successfully closed. Of course, these patients also have a lot of collateral damage. Some have called this obstetric labor complex. So aside from the psychosocial, musculoskeletal problems, nerve injuries, food drops, secondary infertility from all the scarring. So all of this require ongoing care, mental health, social reintegration, physical therapy, all general GYN and OBGYN care. So there's a lot that needs to be done in this area. So it's important also to understand that even though obstetric fistula gets a lot of attention from our FPMRS communities, the burden of pelvic floor disorders, other pelvic floor disorders, such as urinary and fecal incontinence and pelvic floor, is much, much bigger. We don't have very good studies looking at prevalence. There's one study that I have cited here that shows about 30% urinary incontinence, 8% fecal incontinence, and 15% pelvic organ prolapse in low and middle income countries, compared to a much, much lower prevalence of fistula in South Africa, South Asia, for example, or sub-Saharan Africa, where fistula rates are much higher. So there's a lot more need for some of these other pelvic floor conditions. And I think there's reason to believe that women in low and middle income countries may be at higher risk for pelvic floor dysfunction. For example, they have higher fertility rates. So that means they are, one of the big risk factors for pelvic floor disorders is childbirth, especially vaginally. And so higher fertility means that more trauma to the pelvic floor. Obviously, for the reasons we discussed, they're more likely to have obstructed labor, which also increases the trauma to the pelvic floor. They also tend to have a lot more physical exertion. These women, they work 14, 16-hour days. They carry water from miles away. They fetch wood, firewood. They're constantly carrying something, carrying their babies while they work. And that level of physical exertion may have an impact. And on top of that, nutritional status is very much compromised, right? I remember talking to a lot of these fistula patients, and they would tell me even when they were pregnant, they would only get food once a day, and they will be eating the same food every day. So you can only imagine the impact of that on their tissues and their ability to heal and the risk factors for prolapse. On top of that, obviously, there's lack of access to care. For example, I tried my best to find out how many urogynecology training programs there were in Africa before this talk, and there's no information out there. I know of at least 4 or 5, and that may be all there is, to be honest. And in Ethiopia, we started a fellowship training program, as Holly mentioned, and I'll tell you a little bit about it, but there's really hardly any expert training program. So a lot of the care is provided by general OBGYNs who tend to do hysterectomies and colporrhaphies without really much attention to apical suspension for these patients, even though these patients mostly have very advanced stage prolapse. In comparison, there are 62 accredited FPMRS programs in the US alone. So these patients also have, like I said, severe disease for obvious reasons. Every patient that we took care of in Ethiopia when we go to educate our fellows have a stage 3 or 4 prolapse, every single patient. So in summary, I would say large unmet needs for comprehensive pelvic floor care, severe disease, and lack of trained healthcare teams and resources for this care. And so far, what has our response been from our FPMRS community? I would say that in general, a lot of engagements have been short-term surgical missions. A lot of them have focused on fistula care, much less engagement in educational training and health system strengthening, and rare focus on conservative, team approach to care, such as pelvic floor physical therapy, pessary care, and those kind of things, even in the setting when there's surgical care is not widely available. So, we have a lot of work to do. There are a couple of reasons to question short-term surgical missions, and I'm talking about those that are done not as part of an ongoing partnership to build local capacity and continuity of care. So there's actually a really good room for short-term engagements if they're part of a bigger picture of capacity building. So one thing I like you to think about is the idea of social contracts. So there's some ethical challenges with this short-term approach. Social contract is the expectation that society has of physicians to be competent, ethical, responsible to the health needs of society. And in return, society provides physicians the status, the respect, autonomy, right? When you think about short-term engagements, one concern is that society that assumes the risk and inconvenience of training folks, especially residents and fellows and junior faculty for that reason, who go to do these projects, the society that's taking all this risk to train them will not necessarily benefit from the students' future service as healthcare professionals. That's one of the big concern with this. So by allowing them to learn and hone their skills, society is investing in future professional care for them. By allowing them to do research, society is investing in that, transformative potential for research to improve their care. So what happens when that person is not there on the ground to provide that care? So that's something to think about. And this is important to think about, not just in a global health setting, but also when we have our trainees work in low income, kind of low resource settings in the US, and then they don't necessarily go on to help those populations down the line. So this is really something that we need to really to think about. The other ethical thing to think about is the legal framework. So, for example, in the US, we have very strict rules as to who comes to practice medicine. We don't allow residents and faculty from other institutions to come and take care of our patients unless they're certified in the US. And most low-income countries also have those rules, but they don't always enforce them. And often because they have so much need, they're compelled not to enforce them. And they also have, systemic shortcomings. So there's this built-in lack of equity in bidirectional training opportunities and enforcing accountability. And it's at a minimum, it's important for us to be aware of that. These rules are there to ensure health teams do not work outside the scope of their practice, right? Which in a global health setting, you can actually argue that this might be even more likely if you're dealing with a disease that you've never really seen before, or you're not an expert in. And fistula is a good example. And even if you have the skills, if you don't have proper understanding of the social, cultural, and political context, you may sometimes do more harm than good. So it's really important to think about those things as well as we engage in global health. So in summary, I would say, short-term engagement seems to be the case as we're seeing it. It's mostly focused in surgical care, mostly focused in fistulas and less in other pelvic floor disorders, and then less focus on long-term kind of system building. But the good news is that there's a very high level of interest in global health in our field. This was a survey that was done in 2015 at OGS, an online survey of FPMRS fellows, and they got about a 47 response rate. And what we saw from this was that there is 39% said that global health opportunities affected their decision to do FPRS, and 26% said it impacted the fellowship ranking. And about 3/4 are interested in global health during fellowship, and half of them would like to integrate global health into their future practice. So it's a really awesome opportunity for us to because there's so much need to really leverage this interest and to pivot and to build the systems and the trainings that we need for our partners. So I'm actually very optimistic about this. So let's see, how are we doing on time? Holly, how do you want me to leave about 15 minutes for questions and answers?
How about let's leave 10 minutes.
10 minutes, okay. So we end at 1:30?
Yeah.
Okay, perfect. So I only have about 5 more minutes left, I think. So we should have plenty of time.
Good deal.
So let me tell you a little bit about our work in Ethiopia, just because this is kind of a good example of what I've been talking about. But also, I just want to also tell you that, having grown up in Ethiopia myself and really kind of feeling the importance of building the local capacity. For example, I remember going to the local government hospital very regularly as a child because I came down with gastrointestinal diseases all the time, probably from really bad water. And my mom would wake my brothers up at 5 a.m. to go stand in line. And sometimes it would take the whole day before I get to see a physician. And the physicians are usually, they're general practitioners, which means they completed their medical school and maybe had 1 year of training, and definitely weren't pediatricians. I didn't know about pediatricians until I came to this country. And what I do remember is how much I hated going to the hospital because they were dark and dungy and crowded. And I almost always can expect the physician to order, multiple shots of penicillin. I mean, I'm not talking about 1 or 2. I mean, they were always prescribing penicillin shots. And, in retrospect, I know that wasn't the right thing to do for what I had. No one ever talked to me about the water I was drinking and how to prevent it. So if you had asked me then, would I have liked to have a US doctor come and treat me? Yeah, I would have really wanted somebody who has some training in pediatrics and in public health to really be there. But I also know that person will not be there every time I went there. And the better approach would be, if that person came and trained those doctors that were trying to take care of me, or if they worked at the training, academic centers to change the way these trainings were happening, or if they were able to advocate for public health and education of population so we don't get sick so much, right? So, despite this knowledge, though, I still, when I first started working in Ethiopia as a fellow, I started by doing surgeries for prolapse. And I learned just doing it firsthand that was not a sustainable way to do it, because we would operate on like 50 patients, and then we have to turn away like 100 of them, and we will tell them to come back the next year. And we weren't able to train the local doctors because they were overwhelmed by everything else they were doing. So I did this for about 3-4 years, and then eventually kind of pivoted. I made that pivot that I was talking about to like partnering to build an actual training program for the country. So that's our fistula fellowship program. And this was a big partnership. And it came together because, I had this experience working in Ethiopia with pelvic floor patients. And then Dr. Lewis Wall, the founder of Worldwide Fistula, had spent 8 months as a Fulbright fellow at Mekelle University, and they were very interested in starting a training program. The Hamlin Fistula surgeons, where I had spent a year working with, they wanted us to help them build a program where they learn how to operate, how to take care of women beyond fistula, because they were seeing a lot of women with incontinence and prolapse, and they didn't have the skills to do it. And they actually literally came up with this idea, and I was already looking for partnerships in this and joined the Worldwide Fistula Fund board. And our foundation at OHSU was also able to partner with them. We partnered with Healing Hands of Joy, which is an outreach organization that worked with fistula reintegration. And they were able to identify women with pelvic floor disorders because they had a whole network of fistula women who were advocates for women. And we partnered with other NGO like Maternal Health Fund, with the Regional Health Bureau. The curriculum was approved by the Ministry of Health. I mean, basically the timing was right where, the government was recognizing the burden of pelvic floor disorders, and the local doctors were really wanting the training and wanting to lead, and the local institutions like Hamlin Fistula Hospital and Macaulay University were willing to also put in an investment into this work. So that's what, it's a long story. We had a lot of ups and downs. And if you guys want to learn more about this, we have a publication on this last year. You can check that out. But suffice it to say, we've graduated 4 fellows so far, and we have 3 fellows now in the program. And they've done probably close to 1,000 prolapse incontinence surgeries outside of fistula by now. As fistula numbers goes down in Ethiopia with improvement of maternal care, they've been able to pivot towards providing more comprehensive pelvic floor care. This also allowed us to really partner with them on research, because research was a requirement for the fellows, and our fellows could collaborate with them. They've done some really nice work and publication on outcomes for prolapse in that context. This guy we are seeing in the picture, Dr. Malako, after he finished, he actually now became our fellowship director. And Dr. Kim Kinney, who was our fellow at OHSU, now is a faculty at University of Iowa, and she goes back to Ethiopia to teach the current fellows with Malako. So they have continued this collaboration even after this whole experience. And this also allowed us really to work across other disciplines. We did a lot of nurse education, in pessary care and all of those kind of things, pre and post-operative care. Physical therapy training is a big part of what we do. But we also got more into systems improvement at the hospital level, because once you start working in this area, you realize you really have to kind of think about the big ecosystem. So we do a lot of work around quality improvement and leadership and critical care. And it really honestly just takes a village to do this work. And I can see why it's daunting when we talk about this kind of work. But at the same time, this doctors are now taking care of these patients. And I haven't been able to travel to Ethiopia for over a year because of the pandemic and now because of the conflict. But our trained doctors have been providing this care. They don't need us. This is why this is so important. And I would just leave, especially the learners and the residents and fellows in this program, with this message. As I progress in my global health career, and I'm still learning, I realized that there is opportunity to evolve along this career ladder. As clinicians, our comfort is always at that one-on-one level, making an impact at the individual level. And this is more concrete. And surgeons like us, we like this immediate concrete outcomes, right? Completing a case and seeing the outcomes immediately. But we have the power. We have the power and the status and the privilege to do more by daring to go up that ladder, where we can influence systems and policies that can have larger and more lasting impact. And I'm learning how to do that now. But this calls for working across disciplines and interprofessional teams, and using our voices to advocate for health equity globally. And thank you so much. And I will take any questions. Thank you.
Thank you so much. Thank you for taking time. I think everyone was mesmerized by your talk. If there are no, I don't see any in the chat. I thought I would start off. There's a note from Dr. Dion to everyone. What a terrific impact you are having. And that's so true. Can you quickly provide us a quick update with what's going on in Tigray and Ethiopia? Maybe just let the audience know in case, they're not aware of what's been going on.
Yeah, so our partners, the fellowship program, like I said, is a partnership between Macaulay University, which is one of the largest medical training institutions in Ethiopia. It's located in Tigray in northern Ethiopia. And Hamlin Fistula Hospital, which there's a satellite in Tigray as well. And if you guys have heard the news, there has been a conflict in the Tigray region for the last 6 months. It started in November. It's been devastating for our partners, definitely at Macaulay University, very heartbreaking. And for women, because Tigray region was one of the places in the country that has actually met the Millennium Development Goal of reducing maternal mortality by 75%. They are one of the exemplary regions for primary care and healthcare infrastructure. And just over the last 6 months, because of this conflict, 70% of their healthcare facilities have been either basically stopped working, either because they were looted or destroyed by war. And we're seeing an upsurge of fistula patients because women are having babies at home. There's no safe place to have babies. And it's been devastating. And, sometimes, you do this work and this is the kind of time when it makes you realize that, you have to be more political and advocate even at a higher level, and just doing the work on the ground sometimes isn't enough. And that's kind of where we are there. But I have confidence that our colleagues are incredibly resilient and they will rebuild eventually, but it's been really hard.
Okay, let's see, chat. I have one more I could ask. So not all of us can go over to Africa or Southeast Asia or India, to do these types of things. So, what in your opinion can OBGYNs do to help disadvantaged women in these countries that are at risk for fistula and other types of pelvic floor conditions? I mean, we all want to go, but you just can't. So what is the best way we can indirectly help these women?
That's a great question. One way to do it is to provide monetary support to local champions on the ground who are actually doing a fantastic job. So a good example would be some of our partners, for example, through Worldwide Fistula Fund. LEFI is a Let's End Fistula initiative by Sarah. Holly knows these people. It's out of Kenya. She's a prior fistula survivor who started a program where she uses fistula survivors and their families, including men, to form solidarity groups where they would go and do maternal health education. They also do economic empowerment activities such as microfinance and those kind of things. And our organization, Worldwide Fistula, supports that. So supporting them through us or directly would be a great way to elevate them. Same thing with Terawude in Uganda, which is led by Alice, who does a lot of social reintegration work. She's a social worker from Uganda, and she recently opened a fistula hospital, and she has plans to expand it to a maternal health hospital. We are one of her big supporters in the work that she's doing. I personally think that local champions like Sarah and Alice, when they're empowered and they can scale up, they're the ones who are going to be able to make the most impact, and so I would always advise people to look for organizations that are doing that kind of work and just kind of put their weight behind them.
One last question, Rahel. This is from Dr. Margaret Boozer. She's in Women's Reproductive Health Division. Is your program involved in preventative efforts to educate lay midwives and doulas, identify obstructed labor, and improve access to hospitals and next levels of care?
And that's a great question. We definitely have been exploring partnering with our Macaulay University partners because they do have a school of midwifery. A lot of the need is also just making sure we have enough trained midwives when this war broke out. So we actually never got to that part of it. I think it's really important to do that work. Hamlin Fistula Hospital, which is a partner with us in Fistula, they have a midwifery training program, and they do a fantastic job because they recruit women from rural communities who are are interested in being midwives, and then they train them, and then they require them to serve in those communities for a number of years, and they provide support to them, ongoing education, so that they're a resource there. So there are definitely programs like that, and I think we need to do more of that as well.
Thank you. Dr. Tita?
Yes, thank you, Holly. Dr. Nardos, really congratulations on your work, and thank you for making the opportunity to talk to us today. I really enjoyed listening to you, and really identify with the issue of war, because we also have a global health program that was set up for the residents here in this program, as well as other residents across the country, to have an elective. And because of war that is rooted in the colonial, back to the colonial heritage in Cameroon, we've had to suspend that. But we've been able to get some work, keep the research work going on, and maintain a team out there as well. So my question for you is, can you comment on, for those who want to do this kind of work, what are funding opportunities that they could tap into? And then just from your own experience, what are some of the things that, or tips that you have about being successful in global health work? Thank you.
Yeah, thank you so much for that comment and for that question. So in terms of funding, it's hard, and global health is hard. Most academic institutions, they don't really, first off, they don't see the value of that, because it's not an immediate money, business kind of model, So I personally struggled with that at my prior institution. It's a little bit better now that I've moved to a new institution where I have a little bit more resources as part of my recruitment, But what I have done in that context was, first off, I kind of don't wait for people to give me money. I tend to be somebody who just says, okay, I'm going to start a foundation, and we're going to start raising money, and we're going to do Ethiopian dinner parties every year. And we actually grew that over the years, and we were able to raise, enough funds to support the work that we were doing. And people get really excited with your work when they're part of it, or when they have family members involved. So that's not like necessarily a formal kind of source of money, but I want to always encourage people who are passionate that they can come up with ways to make it happen also. They don't have to have like a formal way to do it. In our current institution, we're part of a Fogarty International Consortium, which is an NIH-funded program that provides 1 year salary and support for graduates. So it could be residents, it could be medical students after medical school. They can do a global health research for a year, and they can apply into this either through their own institution, if the institution is part of a Fogarty consortium, or they don't actually have to be part of that institution. They can reach out to institutions that are part of Fogarty consortiums, and the University of Minnesota is one of them. So we sometimes get application from applicants in other institutions. And as long as we pair them up with our LMIC partners, there are a certain number of LMIC partners within each consortium that's part of it. So that's another opportunity to pursue global health through kind of a research lens. I think a lot of funding comes through research in global health. So what I've seen a lot of is, being part of a research project by a faculty who is already funded for a global health work that they're doing. So that tends to be one of the ways in which a lot of learners get funds to go.
Any tips? I'm sure the Ethiopian food really goes a long way with fundraising, but any tips overall for success?
Say that again?
Any tips overall? Just, I know we're running out of time, but just briefly, any tips that you think important for success in global health work?
Yeah. Collaboration is a big one. The reason why our fellowship program has been successful is because it's not run just by one organization. we get all these other organizations to chip in to support the fellowship program so that we have more resources to go into it. So the bigger thing is, we need to get out of our silos. We don't have to own a particular project. It doesn't have to be our project. If we're willing to work across other programs and funding agencies, we can actually be much more successful. So for our fellowship, for example, our Footsteps to Healing contributes towards it, but we're not the only ones. Worldwide Fistula contributes, Maternal Health Fund contributes, and we give credit to all of them in terms of supporting this one fellowship. And so when we do that, we end up with enough funds to support the research work, to pay for travel expenses for the faculty and the learners who go there, and to support our fellows. So that's another advice I have is go more wide in terms of your collaboration.
Thank you very much.
Yeah, you're welcome.
Thank you again, Rahel. It's an honor working with you. Thank you for your message here, and have a great weekend.
Thank you so much. It's been great. Appreciate it.
Take care.
Yeah, you take care too.